Hopefully a bit of a provocative title there. You'll be glad, or perhaps you won't be glad to know, I'm not actually going to answer that. Because there are all sorts of things that you want to sort of take into account. But hopefully can give some steer of what does computer modelling, which is sort of blind to emotion and feeling, what can that help tease out of the data that we've got? And could we have a better sort of configuration of services? So when we talk about modelling, I always like to start with this chap. It's George Box, who was a statistician. And he famously said, all models are wrong, but some are useful. So models are simplifications of the real world. They have to be, otherwise it would be just as hard to understand the model as to understand the real world. And we always make some compromises, some simplifications, but we're trying to tease out some important things, and models, through their simplifications, can help us do that. So we say, let the model inform your thinking, but we're not suggesting you be a slave to a model. It's a problem with geographic models, because I found when it comes to showing maps, I'm damned if I do, and I'm damned if I don't. If I don't show you any maps of saying what the model might want to do in a perfect ideal world if it was given complete control, then if I don't show that, people are disappointed. If I do show it, you can guarantee somebody will find something in a map that they don't like. But anyway, I shall be damned if I do today. I will show you a map of what configuration might look like if we sort of become very dispassionate. So we're modelling on the assumption that it is better, if you are a mother in labour, to be going to a hospital with a larger neonatal unit. They appear to have better outcomes. But if you're in labour, you don't want that brilliant unit to be 2 hours down the road. It's got to be close enough to get there as appropriate. Then, of course, once the baby's born, there's a convenience, or more than convenience, it can be important to the families to have that infant close by. I'm sure I'm not telling you anything you don't already know. But the clinical need is probably most there at the very beginning when the woman's in labour. But it's very easy to say larger centres are better and closer is better. But when we come to modelling, what do we mean by a larger centre? How large should a good NICU be? I could ask that question here. Does anybody want to shout out an answer? Good. There's various pieces of evidence, and I'm sure you've seen them, and you can measure size of NICUs in all sorts of different ways. You can measure intensive care days, whatever. A lot of the data focuses around the number of admissions of very low birth weight infants, so 1.5 kilos. And there's data to suggest that if you pick one cut-off point, for example, 100 very low birth weight infants per year, the outcomes of units which have more than those number of admissions of birthing mothers giving birth there, outcome of those infants is better than in the smaller units. So that's one measure of large. When we look into this, we then had a bit of difficulty understanding how much of the benefit from being born, from the larger unit is actually being born there. So is it just as good to be transferred there within a day or two, or do you have to be born there? And most of the analysis is done on infants who are actually born there, and there's smaller amounts of data on what if you're born somewhere else and then transferred. So we're not quite clear what the answer to that question is. There's clearly a benefit still, but it looks like it might be diminished a bit compared to actually being there right at the very, very start. Because, neonatal care starts during labour, even before labour, really, doesn't it? Also, larger NICUs tend to be associated with larger birth units. So we'd also do modelling of births, which I'm not going to talk about so much here. You read the obstetric literature and you would be forgiven for thinking all the benefits of the larger hospitals are down to them. the obstetricians and the midwives, and the neonatal unit just sort of inherits the better baby from them and the better outcome. You read the neonatal literature and the emphasis is much more what's the neonatal unit doing, and actually teasing these apart is difficult because they tend to come together anyway. Larger neonatal units tend to come with larger birth units. And then you've got questions of larger birth units. Is the outcome better because of better care in labour, or is it the antenatal care? It's just, we can keep on asking why, which is good for an academic because it keeps us in a job. All cut-off points can be arbitrary. So we say, papers say 100 very low birth weights, you've got better outcomes if you're larger than that, and worse comes out if smaller. Do we really think that a unit with 101 admissions is going to be different to 99? And I imagine most of us would say, well, we don't really think that. But they're still useful cut-off points to make us think. But we're always a bit wary of cut-off points. So the model uses continuous variables. It says, actually, I want to try and get as many infants into as larger units as possible. It's also trying to control the size of the maximum unit size to not end up with very, very large units. But fighting against that, it also says, I want to get the infant as close to one of these units as possible. But in terms of cut-off points, they can be useful for illustration. So what I'll be talking about is, let's assume our utopia is we're living in a country, or your area of the country, which can all NICUs will have 100 very low birth weight admissions per year. And all mothers are within 30 minutes of a NICU-equipped hospital, should they want to or have the need to get there. Primarily during labour, but also it's obviously more convenient afterwards. And we examine the trade-offs, because you can probably imagine already it's actually very difficult to achieve both of those things. And when we talk of what's an optimum solution, there is no optimum solution. It's all about where do you want to sit on the trade-off between different objectives that you're trying to achieve. And we call that trade-off, because we like to be fancy and sound cleverer than we are, we call it a Pareto front. And what a Pareto front is, and this is what we're always trying to find, is if we have two objectives, objective A, objective B, we want to have 100% achievement in both of those, which is the top right corner. But we can't. As we try and increase objective A, objective B goes down, or vice versa. And the Pareto front describes that frontier where you cannot possibly improve one performance without harming another. And so you can see this simple example, we have that straight line there, which says you cannot go past that. That's your trade-off point. Where it starts to get a bit mind-bending is this is in two dimensions. You can get 5, 6, 7 dimensional Pareto fronts, and that needs strong beer or coffee or both. I'll whip through this. I just thought I ought to put it in there for reference. Boring technical bits. We locate mothers to LSOAs, which is the areas that the government likes to chunk us into to count us. There's 33,000 of those across England. They average 1.5 square miles. The data we got was based on the neonatal data set, Nina's group. We got permission from 91% of neonatal units, all of the NICUs, not quite all of the others. What we then do though, because these things are actually pretty rare events, the very low birth weight infants, in a geographic model we probably don't want to use the raw data anyway. We make a demand model that's correlated with something larger that we can use, that's more predictive of the future. So we build a demand model that's based on births and also deprivation index. So the greater the deprivation index of an area, the more likely you're going to have neonatal infants that need neonatal care. Travel times are fastest road travel times for this model. Here they were estimated by some commercial software that we've now gone over to sort of fully open source software, which we can share with anybody who wants. The optimization algorithm, this is the bit that sounds clever. It's a bespoke multi-objective genetic algorithm written in Python based on NSGA2. Doesn't that sound good? I'm not going to go into the method. If anybody's interested in algorithms, genetic algorithms, I will be able to bore you for longer than you can possibly sort of tolerate. But do come and talk to me. This is going to be a bit small, but let me talk you through it. These are the trade-offs. Let's just focus the one on the left. Along the bottom is we've got the number of NICUs in the country. And the model is hunting then for combinations of those. There are a bewildering, mind-boggling number of combinations, the way you can organise all of the units if you say, I want to pick one here, one there. If you could capture the entire computational power of the world, send it back in time to the start of the universe 15 billion years ago, start the algorithm running and say, I want you to work out every single combination, you would be a tiny fraction of 1% through all the combinations by now. These things just are mind-boggling. But we hunt for these, the algorithms hunt for the good solutions. So on the y-axis is the number of patients or the number of mothers which will be within 30 minutes of the closest NICU. And as you add in more NICUs, if we go to the top line, the longer line, that's if you can pick NICUs from any place at the moment that has any level of neonatal care. So it could pick the smallest special care unit at the moment, saying, I'm going to put a neonatal intensive care unit there. And we can get up to about 90% of mothers within 30 minutes, if that's the only thing that mattered. And we could pick from anywhere. The shorter line below is say, now you can only pick from where you've currently got a neonatal intensive care unit. One of the things you'll notice is it starts to drop down low. We can't get above about 62, 63%, where with the same number of units, if we could say, oh, now you can pick them anywhere, change where they are, we could get up to about 70, 75%. So it's the first hint that the location of neonatal units is not optimal at the moment for where the demand is coming from. The middle one, again, we're increasing the number of neonatal intensive care units on the x-axis, and we're saying what proportion of infants can we get to a unit that has at least 100 very low birth weight infant admissions per year. And the problem here is once you start to increase the number of units, you start to spread out the admissions too much. And there's just no way of getting this, let's assume it is this magical number that's 100. There's just no way of achieving it once you go above about 45 units. You have to accept some are going to be smaller. It's really nice. We're taking this through parents a bit more slowly than with you. And one of them said, I suddenly get it. It's not just about money, is it? No matter with all the money in the world, we couldn't have neonatal intensive care units in all the hospitals. And it's really nice to have a parent sort of get that. The dotted line that's coming down steeper is, again, picking from the current location. And what we see there is the current locations, again, are a bit suboptimal if the only thing that mattered was getting an infant to one of these larger units, if they're all going to their closest unit. On the right, we combine the two and say what proportion of the population, we've got this utopia where everybody, mother, is within 30 minutes of a large NICU. That's what we want to achieve. How close can we actually get there? And it turns out, if we're trying to combine those two, that at the moment we think if mothers attend their closest unit, it's about 60% is the greatest. But we can actually go up to perhaps about 70% with a bit more free choice. Another way of looking at it is this Pareto front. So we want to be in the top right-hand corner where all mothers are within 30 minutes and all units have 100 low birth weight, very low birth weight emissions per year. And you see, we can't get there. There's a trade-off. And this is why the model can't sort of say, here's an optimum solution. It depends where we want, as a society, as a clinical society, parents, where do we want to be when we can't have everything? How important is closeness versus larger units with better clinical outcome? And that's a difficult trade-off. And the model won't tell you what the optimum is, apart from in some stupid way, like saying which is the point that's closest to the top right-hand corner, but it's completely arbitrary. So maps, people like maps. This might be a bit small at the back, so I'll point out a couple of things. The map on the left is the 2015 list we used of intensive care units. Where are they? And there are 45 NICUs then. I mean, it might have changed a bit since then. We think 90% of admissions could get to a NICU if they're going to the closest, which was of these larger size. 55% of admissions within 30 minutes of home. And 5% of patients will travel more than 65 minutes. The solution on the right is one example, and there are hundreds and thousands of examples which will be sort of similarish. Let me point out just a few things and see if they make sense to you. At the moment we have a unit in Plymouth, and then its next closest unit is Bristol. Now, I used to live in Cambridge, and I used to think everything kind of south of Bristol, southwest of Bristol, was kind of really close together. It was just the southwest. It was like a county, like Essex or something. When you live down there, you realise, actually, these are big distances, and sometimes the roads are dreadful, and particularly caravans and things like that, tractors. Not surprisingly, the model says, hey, why don't you put one in the middle? And it can sustain 100 very low birth weight infants per year. It most commonly picks Taunton. And at the same time, it says, actually, you've got 2 in Bristol. Actually, you can't really sustain 100 very low birth weight admissions in Bristol easily at 2 units. Why don't you consolidate into 1? London. This is where I always upset people. We do this in stroke as well. And there's nothing like 5 minutes, nothing like telling an eminent stroke physician to perhaps best to leave the centre of London and go to Colchester or Southend or something. At the moment, they're highly clustered in London. The model, not surprisingly, starts to spread them out a bit. Some in the centre of London, but some out. And guess what? It likes to put one in Essex or somewhere around there, because there isn't one at the moment. Loads of people live there. No neonatal intensive care unit. I mean, it's kind of obvious, but the model picks up on that. Other bits of consolidation going on. Birmingham, it drops from 3 to 2, for example. Up in the northeast, there's 4 there at the moment, two pairs, and it consolidates them into two separate ones. So they're the sort of messages. And then you can map the travel times, and you can see where, the darker is sort of always gloomier. Apologies to anybody who's from Wales here, in that I've just completely and utterly removed Wales. and Scotland, sorry, yes, and Scotland. Scotland, Wales have gone. And we can start to see what difference can we make? And we're trying to get rid of some of these dark black areas that are always problematic. Isle of Wight, sorry, you'll always be a problem. As will Cumbria. But right, let me just I've got 2 more slides. I'll just sort of mention, I've only mentioned one bit of the work we've done. Other work we've done is we take this and say, actually, now you've got limited beds everywhere, and you might want to go for your closest, but sorry, it's full, and you get transferred on, and we can start to change the number of beds, or actually nurses we change in the model, not beds. We think nurses define the capacity better than beds. What we find is that once you go above 70% real maximum capacity, you start to get lots of infants shooting around all over the country. Health economics modelling, I'm staying away from completely because I find it very hard. They do something clever called instrumental variable analysis, and it helps to tease out confounding factors and say, yes, high volume units really do reduce mortality, they also increase total length of stay, very possibly because they've reduced mortality. But pull out these things. We have a group of parents involved, and the message we get from them is that they're willing to travel further when there's benefit, but they're frustrated, not surprisingly, when there are delays in returning back after the clinical benefit has been achieved. So in summary, we think it's possible to increase the proportion of NICUs that are these larger units with a target of 100 very low birth weights, and at the same time reduce travel distances for parents, which has got to be most important in labour. How you do that is a bit more of a greater spread within the M25 area, introduce NICU provision in Essex and somewhere in the southwest between Bristol and Plymouth, and consolidate some NICUs where you've got you don't really have sufficient admissions to keep them all at 100 very low birth weights. And we do think, and I'm sure you all agree, but it's not done, joint planning and NICUs and large birth centres together could be good, obstetric and neonatal planning together. Thank you, Nina.
So we did start a few minutes late, so there is time for a few questions. Does anyone have a question? Gentleman in the middle there, please.
Thanks very much. I'm Martin Boyd, I'm manager of the Northern Neonatal Network. Interesting to see the projected impact on our particular network, the 4 down to 2. We're actually in the middle of trying to get the 4 down to 3, and that's proved difficult enough. I won't bore everybody with the details of that. I'm bearing the scars from that ongoing situation, and I think it does reflect the fact that it's one thing to model based on the ideal. It's a different thing entirely to acknowledge that we're not starting with a blank piece of paper and we're dealing with things as they are and trying to deal with the reconfiguration based on that. Did any of this take account, or is it just purely theoretical based on the NICU side, of the impact on maternity services? So where you are concentrating the deliveries, because the ideal would be to get the under 27 weekers into the birth centre for NICUs, you're going to have any impact on the maternity services in these reduced number of units?
Yes, we also, alongside this, is a parallel piece of work on maternity services as well, and looking at the effect of planning on those. And there, there's a real tension there in that, there are obstetricians who are quite keen on larger units for better care. You've got a lot of pressure the other way, though, to push as much birth closer to mum's home as possible. So I think they've got an even more tension in the system to consider. But yes, we do. There was one graph I clicked over which was effectively similar work, but on births as well. Yeah.
Are there any other questions? If not, Mark, you're going to be with us for the rest of the day?
Yes.
Excellent.
Yeah.
So there is time to pick up on this conversation over lunch and tea. So thank you very much indeed, and thank you for catching up the lost time.